Hello everyone. My name is Dr. Sudha Seetharam. I am MBBS from Medical College, Kolkata and MS Ophthalmology from Maulana Azad Medical College, New Delhi. And I am the ophthalmology faculty for this case discussion. And with me today, I have a very bright medical student and soon to be Dr. Meghanshi Rajput. And together we will be discussing a series of very common and important clinical cases in ophthalmology. So Meghanshi, please start with the first case.
Thank you, ma'am. So we are here to discuss a clinical case discussion on leucomatous corneal opacity. My patient's details: age 60-year-old male, a blood group A positive, resident of Rajasthan. He is self-informant, so he is reliable, and he belongs to middle class by socioeconomic status. His chief complaints were white discoloration of the black part of the right eye for 1 year and decreased vision in his right eye for the past 1 year. History of presenting illness: the patient was apparently well 1 year back, then he developed pain, redness and decrease in vision in the right eye following an episode of trauma. He presented to the hospital and was diagnosed as a fungal corneal ulcer in the right eye, for which he was on treatment for 2 months. The pain and the redness resolved, but the patient developed whitish discoloration of the right eye. The patient also complains of decreased vision in the right eye for 1 year.
Okay, so Meghanshi, from this history, we understand that the patient had an episode of trauma following which he developed an ulcer, and then that was diagnosed as a fungal corneal ulcer, and he underwent treatment for the same, after which the ulcer resolved, but then the transparency of the cornea was lost, and that's why he is complaining of whitish discoloration of the right eye, and this has resulted in a decreased vision for the patient since the same time, right? So before we proceed, Meghanshi, will you tell me what are the important causes of the transparency of the cornea?
Yes, ma'am. So the corneal transparency is maintained due to the regular networks of collagen fibers, and then the avascularity of the cornea, as well as there is an endothelial pump which maintains cornea to be transparent.
Right. So we have, as Meghanshi has said, that we have the regular arrangement or the lattice pattern of arrangement of the collagen fibers in the corneal stroma. Added to this, the vascularity and the endothelial pump which maintains the cornea in a state of dehydration. So Meghanshi, please tell me which of these important factors has been affected here, which has resulted in the loss of transparency of the cornea?
Ma'am, due to corneal ulcer, it could be the loss of the lattice pattern of the collagen fibers, which is resulting in this.
Correct. Very good. So basically, once the corneal ulcer has healed, there has been corneal scarring, and this has led to the loss of the regular arrangement of the stromal fibers or the collagen fibers in the corneal stroma, and this has led to the loss of transparency of the cornea. Right? Okay, Meghanshi,
Yes,
please proceed with the case.
In past medical history, there is history of hypertension for past 10 years, diabetics for past 8 years. There is no history of asthma, COPD, heart diseases, tumors, and no known allergy to drugs.
Okay. So there's nothing really significant in his past medical history. Please proceed.
Yes, ma'am. The surgical history, there is cataract surgery done in the left eye 2 years back.
Okay, so he has a history of surgery in the left eye for cataract, but he has no complaints in that eye as of now, and the problems with which he has come to us is in the right eye, in which no surgical procedure or any other procedure has been done so far.
Yes, ma'am. Personal history: he consumes mixed diet and has a good appetite, adequate water intake, normal bowel and bladder habit, normal sleep pattern, and he is occasionally a alcohol intake. To summarize my case, a 60-year-old male patient presented with whitish discoloration and decrease in vision in the right eye after undergoing treatment for fungal corneal ulcer. He has undergone cataract surgery in the left eye 2 years back.
Fine. So from this history, what do we expect in our clinical examination? We expect to see a corneal opacity in the right eye, and we also expect to see a PCIOL implanted in the left eye in which he has undergone cataract surgery. So that is our basic expectation even before we start our clinical examination. Okay, so we will first do a general physical examination for the patient and then we will proceed to the ocular examination. So please proceed, Meghanshi.
General physical examination. Patient is conscious, oriented to time, place and person. Weight of patient is 70 kg, height 160 cm. Vitals noted: temperature to be 97.8 degree Fahrenheit, pulse 78 beats per minute, respiratory rate 20 per minute, SpO2 99% in room air, and blood pressure 140 by 90 mmHg.
Okay, so essentially the general physical examination of the patient is normal. Now let's proceed to the ocular examination.
Yes, ma'am. So, ma'am, the visual acuity was first unaided in the right eye, counting fingers at 2 meters, and it was not improving with pinhole. In left eye, it was 6 by 6 and 20 by 20.
Okay, so in the right eye, we find that the visual acuity is very much decreased. It is counting fingers at 2 meters and it is not improving with pinhole. So Meghanshi, will you tell me what is the importance of evaluating the visual acuity with pinhole?
Yes, ma'am. So, ma'am, in pinhole, it is a circular opening of around 1 mm which we use. So, it is basically, if it improves, it is due to uncorrected refractive errors. Whereas in this case, there is no improvement. So, it could be some central or macular pathologies.
Okay, so what you're trying to say is when we check the visual acuity with a pinhole, we have a pinhole occluder. There is a small opening at the center, which is around 1 mm. And when the patient, what this pinhole does is it eliminates the paraxial rays and it allows only the central rays to pass through. So therefore, if there is an improvement in the visual acuity with the pinhole, it suggests that the patient is having an uncorrected refractive error. Right? Whereas in this patient, because it is not improving with pinhole, then we understand that this is probably due to an organic pathology. And of course, there are also a few number of cases where the visual acuity will actually worsen with a pinhole. Like for example, if the patient has a central cataract, like a posterior subcapsular cataract, or for example, if the patient has a macular pathology, then it is possible that the visual acuity will even worsen when you put a pinhole. See, but in this case, it has remained uncorrected. I should say it has remained unchanged even after putting the pinhole, which suggests there is no refractive error uncorrected in this patient, and the loss of visual acuity is because of an organic pathology. Right? So
Yes,
let's
ma'am.
proceed.
Then extraocular movements, lids and conjunctiva, they were normal in both the eyes. The cornea in right eye, it was leucomatous corneal opacity, whereas in left eye, it was clear. The anterior chamber is normal in both the eyes. Pupil is hazy view and reacting to light in the right eye, whereas it is round and regular reacting to light in the left eye. The lens is clear in the right eye, and in left eye, there is a posterior chamber IOL in situ, and fundus was normal in both the eyes.
Correct. So the significant finding is that in the right eye, we have a leucomatous corneal opacity, and because of this leucomatous corneal opacity, the view of the pupil is not very clear, but still we are able to make out that the pupil is actually reacting to light. But
Yes,
Meghanshi, when we actually say that there is a leucomatous corneal opacity or there is a corneal opacity, we actually have to detail a few important things about the corneal opacity. Right, so let us first look at the clinical picture that we have of the patient's right eye.
Yes, ma'am.
Okay, so this is the clinical picture that we have of the patient's right eye. Now, before we discuss what are the important points that you have to look for in a corneal opacity, let me just quickly go through what are the different types of opacities and how we should describe them. So, will you please go to the next slide, Meghanshi?
Yes,
right.
ma'am.
So basically, we know that there are three main types of corneal opacities. We have nebular opacity, macular opacity, leucomatous opacity, and something which is added on to leucomatous is we can also have an adherent leucoma. So why do we have an opacity? Because there is corneal scarring, which results in loss of transparency. So if you look at the first slit that has been given to us, that is the A slit, you will see that this scarring is limited to the very superficial part of the corneal stroma, that is a nebular opacity. So here the scarring is limited to less than 1/3, that is the superficial part of the corneal stroma. Now, if you come to a macular opacity, then you see that the scarring is slightly more. So it is something between 1/3 to half of the corneal stroma has been involved by the process of scarring. And what about leucomatous? In leucomatous, more than half of the corneal stroma is scarred, and sometimes it can extend up to full thickness of the corneal stroma also. So that is what we call as a leucomatous opacity. Now, sometimes it may so happen that when there is a healing of a keratitis, or a corneal ulcer, then there may be a very small perforation, and this perforation is plugged by the iris which comes forward, as you can see in picture number D. So here what has happened is that small perforation has been plugged by the iris which is coming from behind, and the iris, after healing, that part is, the iris is attached to the posterior surface of the cornea. So this adherent iris to the posterior surface of this cornea, which is having a leucomatous opacity, this is called as an adherent leukoma. So this is the theory behind it, right? Now, how do we clinically understand what are the different types, how to classify them as different types of opacities? So if you look at the picture here, that is the central picture, the picture at the center, you will see that there is a very, very faint opacity. So there is a very faint opacity here where this is a nebular opacity. Now, if you look at the picture on the left, the opacity here is macular, and the one on the right, which is very similar to the case that we have now, is a leucomatous opacity. Now, why am I calling one as nebular, the other as macular, and the third as leucomatous? Because see, in the central picture, you see that behind the opacity, the iris details are clearly visible. Just behind the opacity, you are clearly able to see the iris details. Now, look at the picture on the left. In the left, the picture that we have, you can see the iris behind the opacity, but the details are not clear. So behind this opacity, the iris details are visible, but they are not clear. Whereas in the picture on the right, you see this dense opacity, you see that the iris behind the opacity is not visible at all. And that's why we are calling this as leucomatous. So in a nebular opacity, the iris details behind the opacity will be clear. In a macular opacity, the iris details behind the opacity will be visible, but not clearly, the details will not be clearly seen. Whereas in a leucomatous opacity, the iris details behind the opacity are not visible at all. So if we go back to our clinical image, so will you go back to our clinical image, Meghanshi, please?
Yes, ma'am.
Yeah. So here, see, this is a leucomatous opacity, because behind the opacity, we are not able to see the iris at all. Right? Now, how do you know whether this is an adherent leukoma or just a leucomatous opacity? For that, on a slit lamp, we can make a slit and see whether the iris is attaching itself to the posterior surface of this opacity. And if you're looking at with a torch, you can put the torch from the side, and there also you get a view as to whether the iris is attaching itself to the posterior surface of the opacity. So this is how we clinically classify opacities. Now, what are the things that we have to concentrate on when we describe an opacity? So Meghanshi, please go to the next slide. Yeah. So first we have to say what is the size and the location of the opacity. So see, in our clinical picture, the opacity is central. So we will say this is a central corneal opacity. What type of opacity is it? It is a leucomatous opacity, as we have described. Now, what's the size of this opacity? So if you're examining the patient on a slit lamp, then you can put on the measuring slit, and that will give you the dimensions of the horizontal and the vertical parts of the opacity. But if you are examining simply on a torch, then also you can get a rough judgment. So how will you do that? Please put on the picture.
Yes, ma'am.
Yeah. So see here, if we consider that the whole diameter of the cornea is something around say 11.5 mm, then if you look at the size of this opacity, it's like roughly 5.5 mm horizontally and around say 5 mm vertically. This is a rough judgment that we make considering the diameter of the cornea as say 11.5 mm and the diameter of the opacity. We make a rough judgment comparing it with the entire diameter of the cornea. So see, these are the things that we have to describe when we describe an opacity. So we have to describe that the opacity is central. It is involving the visual axis, and that is why we can understand the visual acuity is very much affected. It's a leucomatous opacity, and there is a mild pigmentation over the opacity, but there is no vascularization. Now, what's the importance of vascularization? See, many times ulcers, they heal with the development of vascularization. Now, the vascularization has a final bearing on the prognosis of the case if we have to go for keratoplasty. So that is the importance of looking at all these things during a clinical examination. Right?
Okay.
So these are the points to be remembered.
Then clinical diagnosis: in the right eye, leucomatous corneal opacity; in the left eye, pseudophakia.
Correct. So left eye is a normal pseudophakia, which is because the patient has undergone an uneventful cataract surgery. Right. So,
Yes.
so let us now look at what are the important causes of corneal opacity.
So in this case, healed keratitis. Then the other causes could be trauma, chemical or thermal injuries, post-surgical scar, corneal dystrophies, mucopolysaccharidosis, and then some congenital causes like sclerocornea, limbal dermoid, and Peters anomaly.
Correct. Good. So in this case, we understand that it is the healed fungal corneal ulcer which has given rise to this opacity. So it is a healed keratitis. Now, what are the problems with corneal opacities? The main problem with corneal opacity is obviously a disturbance in vision, right? So see, if we have a centrally located opacity which is involving the visual axis, as in this case, then that affects the vision. Now, how a corneal opacity will affect the vision depends, one, on its location, as I just told you, and secondly, on what type of opacity it is. Now, suppose it is a nebular opacity. Then what is the complaint? The complaint is that the patient will have a reasonably good visual acuity maybe, but he will have a lot of visual disturbance because of the scattering of light. And he will have an irregular astigmatism when you do a retinoscopy or a refraction for this patient. So that's the problem when we have a nebular opacity. Macular opacities, they cause decrease in visual acuity if they are centrally located, and leucomatous opacities, as we saw in this particular case, they cause a definite decrease in visual acuity, a severe drop in visual acuity. So that's the problem with corneal opacities. So how do we treat them? What are the treatment options? Please go to the next slide, Meghanshi.
There could be rigid glass permeable contact lenses, then phototherapeutic keratotomy, keratoplasty, and cosmetically there are colored contact lenses and corneal tattooing.
Correct. So these are the different options. So let us just look at what we should do in which case. See, as I told you, if you have a centrally located nebular opacity which is causing irregular astigmatism, scattering of light, these patients, they do well with RGP contact lenses. Also, if there is a superficial opacity which is not very deep, then we can go for PTK, which is removal of the superficial part of the cornea with the help of excimer laser. That's called as phototherapeutic keratectomy. But if we have a dense corneal opacity, which is like a leucomatous opacity or even a macular opacity right at the center of the visual axis, which is blocking the light rays, then the option is keratoplasty. So what is keratoplasty? Keratoplasty means cornea transplantation. Right? So for this particular case, which is a leucomatous opacity, that is a dense opacity right at the center of the visual axis, which is blocking the entry of light into the eye, then the option for this patient is obviously keratoplasty or cornea transplantation. And if it is an eye without any potential for vision, but the patient is just interested in cosmesis, then the options are to provide him with colored contact lenses or to go for a corneal tattooing. These, of course, have to be done in eyes which may not have fruitful vision, but the patient wants cosmesis. Okay, so for this case, then what is our management, Meghanshi? It's a centrally located dense corneal opacity, so our management is?
Keratoplasty.
Correct. So the management is cornea transplantation or keratoplasty. But here I would just want you to tell me one more thing. See, in this particular case, you have told me that you have been able to examine the fundus of the patient and you have seen that the fundus, the posterior segment, is normal, which means that this patient after keratoplasty is likely to have a good visual outcome if the graft survives. Right? But suppose we are unable to examine the posterior segment, if the opacity is too big and we are unable to get a view of the posterior segment, then what is the essential investigation that we must do?
We can use USG-B.
Yes, we have to do a USG-B scan. The USG-B scan, it helps us to get a basic judgment of the posterior segment so that we can prognosticate the case before we take up the patient for keratoplasty. Right? And clinically also there is one test we can do. We can check for the consensual pupillary reflex in the other eye. So if I have a dense opacity in this eye, you will not be able to check for the pupillary response in this eye. But you put light in this eye and check for the consensual reflex in the other eye. That also is an index of function of the optic nerve of this eye. So if I put light here and I note a good pupillary constriction in the other eye, which is normal, that also tells me that that's an index of function of the optic nerve of this eye. So we can check for the concentric pupillary reflex in the other eye, and we should also do a USG-B scan of the patient.
Okay.
And another important thing that we need to do here is we also need to evaluate the intraocular pressure. IOP evaluation is also a must as a part of our clinical examination.
Okay.
Right? So this is a case, therefore, to summarize, of a patient who underwent treatment for fungal corneal ulcer in the right eye, then developed a corneal opacity. He has a centrally located leucomatous corneal opacity, which is affecting his vision in the right eye. And therefore, but all the other parameters are normal. That is, his IOP is normal, his fundus is normal. So we can plan for a keratoplasty of the patient in the right eye. And as of the left eye, the patient had a cataract surgery and he has a good pseudophakia with good vision. Right? So this is our case. Thank you, Meghanshi.